Hi everyone, today we're talking about spinal tap. Now, what exactly is spinal tap? It's also known as lumbar puncture because we basically inject a needle in our lumbar part of the spinal cord, right? Or the lumbar part of your vertebral column. So, what happens is that in spinal tap, we're trying to withdraw CSF, which is your cerebrospinal fluid. So, in simple terms, if anyone asks you what is spinal tap, in that you basically withdraw a sample of cerebrospinal fluid. And why do you do that? There are three reasons as to why. First is for microscopic or bacteriologic examination. The other is in order to inject drugs, and one is to induce anesthesia. So these are the three reasons. Either for microscopic examination to diagnose certain types of diseases, or in order to inject drugs, or to induce anesthesia. Also, by the way, you must be hearing ASMR at the back of the rain and thunderstorm. That's because there's a lot of rain happening right now. Anyways, moving forward. So, spinal tap is known as the lumbar puncture, and in that you withdraw a sample of CSF. Very simple, and there are the three reasons why you perform it. Now, there's very important thing that you need to know. One is your chorda equina, the other is your filum terminale, and the other is your conus medullaris. These are the three terms which are commonly confused. So for that, you need to know that the spinal cord, it terminates inferiorly at the level of the lower border of the first lumbar vertebrae. So in adults, the lower border of first lumbar vertebrae is exactly the point where your spinal cord terminates, right? In infants, it can reach up to the third lumbar vertebrae, right? Now, how about the subarachnoid space? Subarachnoid space is basically it is below because by the name subarachnoid you can tell it's below the arachnoid meninges layer, and meninges covers not only brain but also the spinal cord. So below this arachnoid layer you have subarachnoid space, and this contains the cerebrospinal fluid. Now, good thing about the structure of our entire spinal cord is that the subarachnoid space, it extends as far as the lower border of the second sacral vertebrae. So up till the second sacral vertebra, your subarachnoid space extends. And this is a very good point because over here only you're going to inject. In the subarachnoid space, you're going to inject in the needle and you're going to withdraw the sample of CSF. And why do we do that? Why not the entire spinal cord? Because in the spinal cord, we do not want any disturbances or any sort of injury to the spinal cord. But when you're inserting it below the level of the terminal point of the spinal cord, below the first lumbar vertebrae, basically you are getting direct entry into the subarachnoid space, which has abundance of CSF. You can easily withdraw that, right? Now, it's important for you to understand the difference between conus medullaris, chorda equina, and filum terminale. So, conus medullaris, right here, you can see where the spinal cord ends. You can see below that point, it ends in a form of a cone. So, this is the cone shape. This is where the spinal cord ends. So, this cone-like projection of the spinal cord is known as conus medullaris. Simple. Then, what about your filum terminale? So, filum terminale is basically an extension of pia mater. So PR matter, again, it's the innermost layer of the meninges, right? The innermost layer. Now, from the spinal cord, you'll see that there is an extension of the pia mater, and that extension of pia mater is known as filum terminale. And this does what? This helps to keep the spinal cord intact. So basically, it binds it to the coccyx so that it doesn't move from place to place. So yeah, this is filum terminale and this is conus medullaris. What about chorda equina? So chorda equina is basically a bunch of spinal nerves. So as you can see here, C1 is going to, for example, if you have a vertebrae, so from that corresponding vertebrae, below that or maybe above that, the corresponding spinal nerve will come out, right? It will basically exit. So in the case I told you that your spinal cord, it ends at the lower border of L1. So you can see this is the lower border of L1 where your spinal cord, actually this lower border of L1 where your spinal cord will end. Here also, let's just try to locate it. This seems like the lower border of L1. See, this is where your conus medullaris is there, right? So beyond that, you'll have all of those spinal nerves, and those spinal nerves, they'll be coming out, right? And basically, all the spinal nerves that are there, because obviously spinal nerves will still be proceeding, all of them together will be known as chorda equina. So this entire bunch of what do you call them, spinal nerves, is chorda equina. And what does it constitute of? It constitutes of L2, L3, L4, L5, S1, S2, S3. And is there L2? Because I told you at the point of L1 your um, conus medullaris is there, your spinal cord terminates. So I hope you understand what I'm trying to say. So chorda equina is basically a bunch of the spinal nerves. Filum terminale is the extension of the pia mater that stabilizes the spinal cord. How? Because it anchors it to the coccyx. And conus medullaris is basically cone-shaped end of the spinal cord. So I hope this is clear. Cone-shaped end of spinal cord around L1 to L2 vertebral levels in adults. It marks the terminal end of the spinal cord. Filum terminale, thread, thin fibrous, a delicate extension of pia mater from the conus medullaris. It anchors the spinal cord to the coccyx, stabilizing it. Cauda equina, horse's tail, a bundle of lumbar, sacral, and coccygeal nerve roots descending below the conus medullaris. Now, uh, this is basically a summarized table. If you want, you can read that. Now, Cauda equina, it has L2, L3, L4, L5, S1, S2, S3, S4, S5, and coccygeal 1. So all of them, they basically form a bunch together, or they just form a bundle together, and they exit from the lower vertebrae. How do they do so? They travel downward in the spinal canal, and that basically, as they're traveling down the spinal cord, there's a bunch of them. They all form a horse's tail, called equina. And these cauda equina, the nerves in here, it supplies lower limbs, bladder and bowel control, perineum, and in case of cauda equina syndrome, in which these nerves can get damaged or pressed, there will be severe back pain, saddle anesthesia, bladder or bowel dysfunction, weakness in legs. Anyways, this is a lot of information. Our main thing that we had to focus on was spinal tap. Now, in spinal tap, what you do is the person is asked to lie down like this, on their side, right, like this, on their side. And what happens is that you can see here, this is the conus medullaris where the spinal cord is terminating, and this is the subarachnoid space. So the needle is injected, and also here you can see the needle is injected in the subarachnoid space. Now here you can read, we are saying that the lower part of the vertebral canal is thus occupied by the subarachnoid space, which contains the lumbar and sacral nerve roots and the filum terminale. A needle inserted into the subarachnoid space in this region usually pushes the nerve roots to one side without causing any damage. This is the good point. And then the patient is lying on his or her side or in the upright sitting position, or they could also be possibly sitting. And what happens in this case is the vertebral column is flexed. And when the vertebral column is flexed, this is perfect case scenario because the space between the adjoining lamina in the lumbar region is maximum. This is going to allow easy, basically, you can easily maneuver the uh, syringe or needle inwards, the needle basically inwards. Now, there's an imaginary line. If you touch both of your iliac crest and form an imaginary line, that's the fourth lumbar spine. So around that point, you can insert the needle. And obviously, you have to follow careful aseptic techniques and local anesthesia. And then you have to pass down the lumbar puncture needle, and it should be fitted with stylet into the vertebral canal above or below the fourth lumbar spine. And these are the layers it's going to pass from: skin, superficial fascia, then supraspinous ligament right here, then intraspinous ligament, then ligamentum flava. And after ligamentum flava, it's going to pass these internal vertebral veins. After the internal vertebral veins, you can see areolar tissue containing the internal vertebral venous plexus, then dura mater, and then finally arachnoid mater. So, as a stylet is withdrawn, a few drops of blood might escape. This indicates the point that the point of the needle is in one of the veins of the internal vertebral plexus. So it means you need to keep on advancing until it reaches the subarachnoid space, right? Because up till now, the vein, the stylet or the needle has just reached the internal vertebral veins region. So you need to advance it further so that it reaches your final layer of the subarachnoid space. And if there's any sort of stimulation, you're going to notice the twitching in the respective muscle. And the normal pressure, how can you note the pressure down? So for that, you need a manometer. You need to attach this to your needle, and this is going to tell the readings. In the recumbent position, recumbent position is basically this position where a patient is lying down sideways. The normal pressure is about 60 to 150 millimeter mercury, and there'll be oscillations corresponding to the respiration and the arterial pulse. Now, if there's any sort of blockage in subarachnoid space in the vertebral column, there'll be difference in the readings. But how so? I'll tell you. So basically, why will be there a blockage? It could be because of a tumor. It could be because of a tumor in the spinal cord or the meninges or any other reason. So what's the test for this? The test is that you need to compress the internal jugular veins. And normally, what will happen if you compress the internal jugular veins? The cerebral venous pressure will rise. When cerebral venous pressure will rise, there'll be a decreased absorption of CSF in the arachnoid granulations, because of which the CSF pressure will rise, right? So this is a normal case scenario. If you touch the person's internal jugular vein, compress it, you'll notice that CSF pressure will rise because less of the CSF is being absorbed in the arachnoid granulations. But in case of a tumor or any sort of other reasons for the blockage, what will happen, even though you're pressing the internal jugular vein, but there is no rise because there's no rise in the CSF. But why is it so? This is known as Queckenstead sign. Queckenstead sign. Queckenstead sign. So Queckenstead sign is basically no change in pressure even when you're pressing the internal jugular vein. So here you can read this. It's a clinical sign tested to detect blockage of the spinal subarachnoid space during a lumbar puncture. Normally, when jugular veins in the neck are compressed, intracranial pressure rises and this increases CSF pressure in the lumbar region. So, what's the test? You need to perform lumbar puncture and measure the CSF pressure. Then you have to compress both the jugular veins in the neck, both in the right and the left side, and the CSF pressure rises rapidly and then falls when compression is released. This is normal. But in case of positive Queckenstead sign, there'll be no rise or delayed rise in the CSF pressure. This indicates blockage in the spinal cord. So already there is blockage, so it's not going to rise. The pressure is not going to rise or because there's already blockage there. I hope you're understanding. And what are the causes of blockage? Spinal tumors, herniated intervertebral disc, spinal cord compression, tuberculosis, meningitis. So if CSF pathways are open, the pressure is going to rise quickly uh, when you're blocking internal jugular vein. But if you're even blocking internal jugular vein, but there's no pressure increase, that's because there's already some tumor present because of which the pressure isn't rising significantly. So basically, here, jugular compression increases pressure in brain, but if CSF pathway is blocked in the spinal canal, then pressure cannot reach the lumbar CSF, so no pressure rises